Okay. Good morning. Welcome, everyone. Thank you for coming to Primary Children's Grand Round Annual Chief Resident's Choice Lecture. Everyone in person in the auditorium and our Lehigh Auditorium, and our speaker, Julie Hauer, here. I am Dr. Miguel Canaco, one of your pediatric hospitalists and course director. Today's Cloud CME claim credit code is 40541 for everybody to claim. And remember, um, next Thursday is the 18th. Online questions go in the live chat, and if you're in the auditorium, just raise your hand, and Dr. Howard can call on you. And you don't need to repeat the question. We'll just use the overhead mics. And here is the safety award. So if you see someone using a error prevention technique at our hospitals or clinics, nominate them for a safety award. And now Dr. Alicia Hughes will introduce our speaker and give the safety story.
Morning, everyone. I am Alicia Hughes. This is Dane Hegdahl. We're the chief residents for this academic year. First, for our safety story, we wanted to share a good catch by one of our residents recently. We had a resident come on service taking over care of a patient with Kawasaki disease. And this patient was on protocol, including treatment with aspirin. And our resident astutely noticed that the patient had a recent influenza diagnosis and was at high risk for Rye syndrome, prompting a interdisciplinary discussion about the risk of the patient being on aspirin. And this stop and resolve potentially prevented an adverse event for this patient. There we go. And then to introduce our speaker for today, when we were faced with the first daunting task of our chief year last December of selecting any topic we wanted for Grand Rounds, we decided to focus on identifying what we felt was an area of significant need and opportunity for our residency program and hospital as a whole. And the need that we identified was this: as we are caring for increasing complexity of patients in a healthcare system that is not designed to adequately serve them, part of our responsibility, we feel, is to provide the highest standard of family-centered care to every patient, regardless of how complex they are, and adapt our systems to prioritize the quality of our care. Once we identified that as our focus, Dr. Hauer was the clear choice. There is no one who is more dedicated to advocating for this need than her, and we feel honored that she would come with us today.
And I'll just share that Dr. Hauer is a faculty at Boston Children's since 2009 and a medical director and now consultant at Seven Hills Pediatric Center, a long-term care facility in Massachusetts. Starting 30 years ago at Gillette Children's in Minnesota, she's focused on children with severe neurologic impairment who have multiple comorbidities resulting in complex care and decision-making needs. Her work includes complex symptom treatment and a framework to aid iterative decision-making and end-of-life care. She has written 2 books, provided the medical content for Courageous Parents' Neurojourney, and is focused on the next generation engaged in this work. Welcome and thank you to Dr. Hauer.
So I already had such high regard, and then the time already that I've had here has just kind of exploded that, starting with thank you to Alicia and Dane in terms of the facilitating a lot of details and picking me up from the airport yesterday even. And I also wanted to acknowledge that why it's such an honor for me to be here is, again, I already had this high regard for many individuals in palliative care, complex care, and hospice teams. And that really reflects individuals I know and also the literature that I often reference. But again, already I've just felt so welcomed and appreciative of being here. So I'll be focusing on children with SNI, and my objectives are organizing medical information in an iterative manner related to the medical problems that children with SNI can have, and then utilizing language strategies adjusted to stages in that framework. I have nothing of relevance to disclose. So as you know, children with severe neurological impairment, which I will refer to as S&I, are children who have impairment of the central nervous system, resulting in both disability and medical complexity. The medical problems that such children have are not solely what defines them. All children with S&I have abilities that are identified through the meaningful relationships and activities. And I really want to thank Nancy, her colleague Stephanie, Ames for that impactful article from 2024, really highlighting how discrimination still occurs for this patient population. So we obviously become involved with such children, though, because of their problems. And I'm going to be focusing on the chronic problems due to the impaired nervous system. Such problems can often be well modified, often for many years. Yet, due to lack of cure of such problems, that might not always be achieved. Benefit can occur, but later be lost. And in a subset, that benefit may never occur. And before I jump in, I included this quote from one of my favorite musicians. But I really just always like to, before diving into the specifics, the skills that are required of us, and of the communication skills specifically, that as important is our presence with parents and our listening. And that seems less active, and we can't always know the impact, yet it will have an impact. I wanted to also start with the really remarkable literature from the last 5+ years that has highlighted, that continues to highlight the parent perspective. And I just wanted to start first with literature about quality of life. So parents, not surprisingly, often indicate that it's important to them that their child's able to enjoy meaningful activities and relationships, that their child is comfortable and awake when well. Parents, as well as ourselves, we recognize that that's temporarily lost during an acute illness and at following surgery, with the intent to return to that. Parents also recognize in an anticipatory way that they can envision that that might be lost as problems have a growing impact on their child, and specifically then growing impact on quality of life. And there are some articles where parents are even able to articulate either in an anticipatory way or in bereavement literature that they can envision or have experienced their child falling below a quality of life level in which life-sustaining treatment doesn't make sense, or the continuation of those interventions. When naming this, though, I find it so important to recognize, and I have to do this in my own individual work, that it's not a line in the sand in the future. It's a point in time where changes occur and we attempt to adjust and modify the outcome, while we're also considering what is likely to occur. So that means it will always involve looking back. It's not that it occurs and then it just becomes this easy point in time to shift what the goals will be for a family on behalf of their child. The other literature, I just wanted to summarize, not surprisingly, first and foremost, parents will tell us, value my child, be committed to my child, give me honest information, and always give me permission, support my hope that I also will have along this way. Value our perspective and expertise and utilize that, partner in decision-making. And what I'll be focusing on particularly is prepare us for what can lie ahead. And so I just wanted to indicate this as this medical framework that is iterative, and then the partnership with parent perspective, where we are seeking to gauge how to pace further exploration of information with an individualized parent. I also wanted to just briefly reflect on trajectories. So starting with just a nebulous trajectory, obviously we don't know the future with certainty. And when we're encountering a child, we're attempting to give the child the best health possible, the best quality of life possible. And when it changes, to restore baseline or achieve a good baseline, even if it's not the same prior baseline. Understandably, where we particularly have a focus is when there's acute decline in health. These are points in time where we're striving to achieve recovery. These are points in time where the term needed can then pop up because it's what's needed for recovery. And then parents have their past experience when there's recurrent events where a child has had improvement from new interventions and has recovered from acute decline that has occurred recurrently. So how that child has improved last time is a story that impacts how a parent anticipates the future. What I wanted to do is now expand this into the longitudinal lens. And I know what I'm doing is naming components that you factor in, that you utilize. I hope it's still helpful to come back to considering how we give that longitudinal lens. And specifically, a child with SNI who continues to have a return of problems, continues to have acute health event episodes that return, because then we have at points in time a history to reflect back on, so that we're not just focusing on did we achieve recovery. With past events, what have we achieved? We can look back, what has occurred, what has been utilized, what has been gained, and importantly, and I have to say this at the onset, in a supportive way, starting to reflect, are there aspects that are being slowly and insidiously lost early on at times where we're still looking to achieve a recovery? So the idea is that we're not just looking at did we achieve recovery, but did we modify going forward the long-term outcome? And the past information can inform in an iterative way how we anticipate as well as hope to achieve. And what I'm just highlighting here is that we're giving room that reversible is becoming less likely at times when we have interventions to consider and introduce to parents. What I wanted to do next is also very explicitly name the types of problems that children with SNI have, and I know you know this, but to be clear that the problems due to the impaired nervous system, specifically in children with SNI, given that these are problems that understandably can impact health and quality of life. Again, these are problems that we can often modify for many years. Yet due to the inability to cure the source, these are problems that are at risk for either remaining or becoming intractable later. And then just for organizing the information, I arbitrarily broke it into 4 categories. So I wanted to start with the first 2 categories because these are well recognized. So it's neuro problems, given that we have a test to know a child has a seizure disorder, and we have criteria to know that a child has spasticity and or dystonia. And then it's we can easily recognize when a child has acute on chronic respiratory exacerbations. And you'll continue to see this theme that we can equally demonstrate commitment to improving the outcome, and then in an iterative way, give an honest reflection based on what we have and have not achieved and what we hope to achieve going forward. As we both hope for recovery when that's the goal right at this point in time, while we also have a supportive lens on considering what will we continue to achieve in the long term. And this is really introducing the reminder to us to recognize that any problem due to the impaired nervous system has the risk to become treatment resistant, to have decreasing ability to reverse the long-term course. And then the other categories I wanted to acknowledge it's a harder category, and I know many of you know this is where I particularly focus my attention, is symptoms generated due to the impaired nervous system. And I just want to simply frame these as neuropain sources due to the impaired nervous system that generate pain. So central neuropathic pain due to alterations in the thalamus, as well as alterations in other areas of the central nervous system that there's starting to be added recognition, including the basal ganglia, the areas that are part of processing the sensory input from the body. Then obviously autonomic dysfunction, where it can result in sympathetic hyperactivity features and visceral hyperalgesia as a result of sensitization of the visceral afferents. And then just the reminder and recognition that all of those sources in some children will be a reason why there continues to be recurrent GI pain and or emesis. So these are sources important to consider when there's insufficient improvement after treatment of known problems. So following those, sometimes the need to repeat the comprehensive history, examination, diagnostic tests, diagnostic trials. And it's important to consider because there's evidence indicating interventions to help lessen the impact of symptoms generated by the impaired nervous system. And then recognizing that chronic pain can also worsen a child's underlying spasticity and dystonia and seizure disorder. And then also, this becomes an important part for parents of naming the impaired nervous system as the best explanation why, in this comprehensive effort, there continues to be recurrent pain and GI symptoms in some children. And I just want to acknowledge, I'm sure many of you are familiar with Courageous Parents Network and then specifically NeuroJourney for children with SNI. That I know in CPN, one of their very important mottos is you can't tame it if you can't name it. And so the importance of being able to name everything as we best understand it to parents. It helps them kind of grapple with what does this mean for my child. So obviously I've kind of just outlined details that you know about trajectory and then the types of problems that can occur. What I next wanted to focus on is how we can provide an iterative lens to what we anticipate. And throughout this, always really encouraging or supporting hope, even when we know there might be a diminishing ability to achieve what we're hoping to achieve. And to do this, I want to first focus on the neuro problem sources, given that those are problems that are mostly managed with medications and sometimes surgical interventions. So the first part is straightforward. It's appropriate to consider with first two medication trials directed at the problems we're attempting to manage that I can focus on. I expect benefit with this first medication. Many children like Grace have benefit, though not all have the same degree of benefit. Those who have inadequate benefit, many go on to have benefit with the addition of a second medication. And the idea is that we expect this to provide benefit. And we also, though, acknowledge that we can't guarantee that the benefit will occur. So it's also an anticipatory statement. Where I spend most of my time is in the next stage. I call this the stage where problems without easy answers, and yet improvement is possible. So with third, fourth, fifth, whether it be a child's seizure disorder, their dystonia, their recurrent pain events, though there is a decreasing number of children who will have benefit with more medications, there still will be some who will, and why multiple medication trials do make sense. But by naming it, we also give parents, and obviously including parent perspective in this, which I haven't yet got to in the detail it requires, it also gives parents the permission to name when they don't see benefit in whatever next number trial there is when we can't guarantee that, versus the other side where parents want to make sure they've turned over every stone possible so they can be confident that the best effort was made. So again, I just want to acknowledge that in this is also that shared process that would take place. But here is where I just focus on benefit is possible with this next intervention, though it may not be as much as we're hoping for by adding this on. Or if it's a child who's had benefit and it's later lost and there's been the repeat of the comprehensive assessment and the symptoms continue, I can acknowledge it may not be as much as we've seen in the past. Then I do like to just kind of outline steps. With this next trial, I would expect to see benefit in the next 2 weeks or in the next 4 weeks. In the short term, we'll identify a short-term care plan to help lessen symptoms in the short term. Some parents prefer to prepare if we don't see benefit and to know what else can be tried. Other parents prefer to focus on the positive and only talk if needed. What would help you most today? So that's obviously an example of adjusting to an individual parent, and in this case, communication preference or planning preference. There's also other skills in adjusting to parents that get at higher complexity within emotional needs, obviously supporting spiritual frameworks that are a guiding force for parents as just broad kind of categories. And then one other component in this where we're striving to achieve a good baseline is that at times I will just briefly name, I notice over the last several years, we've had kind of this back and forth where we some interventions don't have the benefit we hope, some do, and then it's later lost again. One aspect is I want to explore the emotional component. It must be hard to continue to experience this up and down roller coaster, so we can explore that. But I also, again, want to be naming things that are relevant to where their child's at, and then explore that in a manner that makes sense to a parent. And then obviously this is a simplification of iterative, but there are times where sharing a worry with a parent in the context of the parent has trust, both in our individual trust of other medical teams involved in their child's care, where I can share a worry. I'm worried that this is getting harder to improve. We'll talk about our next options that can make sense to try. I just wanted to acknowledge that I've noticed over, again, just naming a time course, over the last 9 months, we've been having more trials, and benefit that occurs seems to have benefit for a shorter period of time. Is this consistent with what you see? But the idea of both naming, and then equally important, again, coming back to the parent perspective, there are times when a parent recalibrates my perspective, where I'm reminded about how well their child's thriving. We spend time focusing on details, continuing to strive to maintain that or even improve it further. Or for a family where they are starting to have the same worry, but they haven't had that as an active thought. And so the other part by having a question is allowing a parent to be actively engaged in such impactful and difficult conversations. The other part I wanted to focus on is time to prepare for the risk of respiratory failure. And the way I want to just think of this is that children at the beginning of their condition, some have details to indicate risk. Child with severe hypotonia, lack of a cough and lack of a gag reflex, or it might be that the child has a genetic disorder where we know that some will have a stable course and some will have a rapid decline in the weeks to months to come. Or it could be a child has a neurodegenerative condition where we know that it's a condition where there's decline over several years. The other would be the child later in life. Later in life, it's going to be much slower as there start to be respiratory illness, hospitalizations, our efforts to improve the outcome, and identifying times to introduce a risk, again, for the idea to prepare for the future to the degree the parent wants to. Before naming that risk, I have to imagine you have equally useful and probably even more brilliant ways to approach this. Mine is to just acknowledge I will share a risk. I know you know our teams are committed to grace doing as well as possible. And when I share this, I'm not looking for us to talk about a decision. I'm looking to share it, and then we'll figure out together what makes sense to talk about today or at a later date. And then I can name it. With the information we have about Grace, Grace is at risk for her breathing to fail in the next year. Or if it's later in life, I would frame it as in the next several years. Though I and others don't know this with certainty. I know this is hard to hear about such a risk. We know from parents they find it even harder if they're not prepared for something that we know might occur. And then the way I just want to acknowledge this is, again, because an important part of this is adjusting to the parent in terms of the pace of information. If a parent prefers to acknowledge that risk and then put that risk aside, I'll just share an observation that for me is a hypothesis that not for all, but for many, it actually enhances trust if respiratory failure event does occur. They trust that we are giving honest information. They trust that we're committed to preventing that if possible. And they've had trust enhanced because we adjust how we talk about things to their preference also. And then I just wanted to name, because I obviously can't go into as much detail as this deserves, I just wanted to name a few components. For me, it's just a few high-end components when being at a time for a parent who wishes to talk further, or just to acknowledge that when respiratory failure occurs, we will try to judge, but we can't judge with certainty how much reserve grace has. What we know is that some children will have the reserve to recover from ventilation, have benefited from that, so that they recover to breathing on their own. Some children don't have that reserve and don't have that ability to then recover. When that occurs, where ventilation continues, it results in two other new decisions. Specifically, should we place a tracheostomy tube? Should we continue long-term ventilation at home? And again, the idea that in times where a parent wishes to explore more and it's not in a crisis, there can be benefit to reflecting on information that's impactful and allows further discussion about the impact of such options on child as well as family, loving decisions that parents make, as well as other details to factor into that. One other aspect I wanted to acknowledge is there are times where my role of improving chronic problems that impact quality of life and secondarily impact health, such as dystonia and chronic pain, that when those problems are intractable and harder to improve with multiple interventions, and in the context of trust, where I know that we've been attempting as best possible to achieve trust in the effort that we're committed while we're acknowledging the difficulty of improving the problem, there's a point in time when I do want to introduce a suggestion to a parent and that suggestion would start out the same manner. I have a suggestion for us to consider without a need for a decision. What I would suggest is that that we not use intubation in the future if Grace's breathing were to fail. And that gets at a worry I have, that I worry we can support her breathing, but with that support, we can't improve her other problems. And use of ventilation is also harder to improve. And again, having to pace that parent perspective, put it aside. That also means there might be times when, in my best skill, a parent is initially angry. I know that's anger at the circumstance, not at me, but I also know I have to, again, recalibrate back to a parent and how to kind of proceed forward. One other aspect why I wanted to come back to the trajectory is coming back again this idea of commitment to improving outcomes where we're considering that reversible is becoming less likely. And I wanted to start with the concept of trust. So it's hard. There are times when I find myself worrying, am I giving up too soon? Am I trying hard enough? If I, as a seasoned person, have this, I know that others who are earlier in their stage of providing care for such children have that as a worry. Teams have that as a worry. And obviously, we have discussions as disciplines so that for any given problem, which disciplines are necessary. But I just wanted to highlight this with the idea that it enhances our trust that changes in a child's condition because of their problems is a result of their condition. not due to lack of effort to improve it. And then that also becomes a transparent part with families so that we can transparently, iteratively come back to what we're trying to achieve, worries that we might have, interventions that make sense to try. And then one other aspect of trust is that we celebrate when we achieve a desired outcome. Even if it feels like a small victory, and parents have poignantly referred to this as inch stones. I actually consider this a time where I know to be prepared that whatever we're seeing might again be later lost. But I put that aside. I have to put my side of worry to ensure that I'm showing parents not just my commitment, but our collective commitment to achieving that. And that is something worth celebrating. It also, as it occurs, as that roller coaster, is obviously emotionally exhausting. The other is, I did want to again rename that aligned view, coming back to that. As you've seen, I attempt to describe something with several sentences and then ask a question to ensure I'm giving space for parent to share their perspective. And I'm not even giving it due justice because that often ends, ideally, is the majority of some conversations where the parent voice is driving a lot of the discussion, not me trying to introduce a lot of detail. But with that aligned view, again, that sometimes what I start to wonder can be recalibrated when I have the parent's perspective, when we reflect on photos. I can realize the need to put aside information and focus on a parent's emotional needs, the role of our team and psychosocial support particularly. I'm obviously again naming that in this process, being prepared for pacing information. This can take place over weeks to months. The other part is I want to acknowledge in this, with pacing information, there's understandably a worry that, but what if something occurs? The way I look at that is that will occur whether we have those conversations or not. We're planting seeds that might be beneficial for a parent with the next event. And I myself, and maybe part of this is my own coping, but when interventions are being used to achieve recovery, and I'm at a phase of having worries, I would prefer to focus on the interventions needed to achieve recovery, but starting to also consider what would be a time interval to expect that to occur in. So that's also part of it. But to lessen a parent feeling that they're having to grapple with two considerations at the same time. There are times we have to put these worries aside and focus on several weeks of where a child's at, 3 to 4 weeks. And then one other part is when considering technology, I had that slide about whole child, the idea being that we look at all potential problems the child has so that if we're considering parenteral nutrition, if we're considering long-term ventilation, that we're also identifying what else is occurring that might continue with that technology so that also can be ensured that there's some reflection on that in the discussion. This one I'm going to skip. So the other part I also wanted to include in this is the benefit of reviewing, are there new features that reflect neurodegeneration? Given that children with SNI have less physical ability, we don't see decline in the same way we see in elderly. And so in fact, the tools that are used to track that wouldn't apply to this population. And I can envision that somebody in the future will identify one that's relevant for this population. What I first wanted to just identify is literature that's almost predominantly from adult literature of adults with disorders of the central nervous system, where it's well described that there are sensitizing events following surgery and as a result of acute illness with systemic inflammation, in which the nervous system can be sensitized and result in new features that can be transient as that inflammation decreases and child recovers from surgery, and can in some children persist. And those sensitizing events when a problem persists can and may reflect neuronal cell death. We also know that just observationally, for some children with SNI, that neuronal cell death that comes with aging might occur at a much younger age in the population. So again, this can occur in children with static conditions, not just neurodegenerative diseases. So I just wanted to name a few considerations that can be asked about so that, again, we have a whole picture of the child. As we're looking at, is there some insidious decline that's occurring? And I'm just going to name a couple of these, but what I do is I identify what are the different types of changes that can occur and how does that localize back to the central nervous system, meaning that there could be changes in the area that regulates different aspects of arousal and pain as examples. One example is that a parent might bring to our attention, or we can ask about, that they start to notice this new feature in their child, that they're having these areas of redness, of flushing of the skin, and it comes and goes intermittently. Or it might be that they notice that the hands and feet are intermittently cool and mottled, and it comes and goes, and it's not due to the child's body position. When seen and when there isn't a better explanation, I can acknowledge that those features can reflect changes in the area of the brain that controls autonomic function. In this case, the autonomic constriction and dilation of blood vessels that results in that flushing. And when we see this, this can come and go in children for years, and so it doesn't worry me. If you see it returning frequently or persisting, let us know and we'll talk more about that. Another one that's more impactful is that children can develop edema where it's not due to acute illness with a fluid bolus, where you often see transient edema. And it's not due to organ failure. There's no cardiac, renal, or liver failure. And this is described really in adults with disorders such as multiple sclerosis and brain tumors, where there can be development of edema that's referred to as neurogenic edema. And due to changes in the vasomotor center of the CNS. And again, this can be described, this can come and go. For some children, this might start to worsen in the months to come. If it returns more frequently or persists, we'll talk about what that might mean for Grace. And I know this might sound odd to bring this to attention, and yet it's another detail that can be part of the whole child picture that can help inform. And I find this is one that when it's named, for many parents, it's kind of this aha of, oh, well, that makes sense. Because it's almost like giving them permission to see the decline that's occurring in their child, because we're actually now naming an area of the brain that has changed and is the reason for the features we're seeing. Finally, I just want to acknowledge rate of decline. Obviously, some conditions have a rapid rate. The longer a child has lived with their condition, the slower the decline is, and reversible it is early. That also means it's harder to see the slower insidious decline. And I know I've kind of talked about how the benefit of seeking details, given the benefit of time to adapt to what might be a shifting future as we explore what's being gained and lost. And just that reminder that all of these problems due to the impaired nervous system are chronic problems and require that longitudinal view, not just what do we achieve in the short term. And then insidious decline can later, and often does very rapidly, progress at some point. I just wanted to end with a couple of coming back to the language of as more interventions, giving acknowledgement to, we hope for benefit, this can make sense to use, here would be side effects we'd consider to factor in. As we've seen in the past, if benefit does occur, it might again be lost, but now our decision to use this, it makes sense to focus on achieving that benefit. I also, though, want to, in that dialogue, seek a parent perspective. You know Grace best, as we've been talking about that this might help, but we can't guarantee it. What do you think may happen as you think about the conversations we've had? Though it's okay if you're not sure. Again, though, the idea of a question so that a parent is actively engaged in reflecting on what this might mean. And then the emotional support as we're talking about benefit that might occur but can't be guaranteed. Coming back to, again, it must be hard to hear us talk about this. Tell me more about what this has been like for you. And I'll also acknowledge, I recognize I have a high skill set. There are times when I think it's more important for the parent to solely talk with our social worker for the psychosocial support so they can talk about how crappy all of this is, and they don't have to worry that I'll take it as a negative, that they don't trust what I'm doing. They should have that space, because I am in a role of also thinking about what treatment strategies might make sense, that we change the dynamic. Parents don't want us necessarily to think they don't trust us, and they need to talk about how hard this is. And then finally, also another aspect to reflect on is hospitalizations. And this isn't something to do every time, but each hospital stay, I'm so glad how it helps Grace recover. I was also been thinking a lot about Grace as I think about the number of hospitalizations she's had, and you're her best expert. How do you see Grace doing in between the hospital stay? How do you see her doing in the hospital? So again, creating the space to reflect on probably something that's more impactful, which is my child benefiting from the approach to care we're currently using? And then I want to end with one final part, which is in decline. And I'd say quite a few where that can also be a phase where there's a higher symptom burden that's harder to improve with medications. So there can also be a time when I can name Grace may be at a phase in her life where the best way for her to be comfortable is to let her body rest more. As an example, I'm so glad for all of the years of benefit Grace has had with cough assist and overnight BiPAP. I'm starting to wonder if she's losing the benefit she's had in the past. I'm also starting to wonder, it might be that her body doesn't tolerate the stimulation from these interventions as they did in the past. And again, naming something that then can be more explored with a parent. So I'm just going to end now. I'm not going to go through this. This is just summary points, but the point I wanted to make is that I imagine you do this, but the power of teams creating checklists for key components to factor in at different stages. I get fatigued. I always return to my checklist. And it helps us feel in our confidence that we're exploring different components. And then I want to end with, most importantly, which teams are best suited at different stages. So with the 15 minutes or 16 minutes we have remaining, I want to thank you for your attention, or at least showing wonderful attention. And I would welcome any question or comments that others would like to share. So thank you.
Thank you so much. The code is 40541 for everybody to claim that credit. And we could just take questions. You can call on them. And you just have the overhead mics. Go ahead.
Dom.
Thank you. That was awesome. We've been so excited since we found out that you were coming, and I really appreciate our chiefs having the wisdom to invite you. I also want to highlight that Dr. Hauer is a great mentor in our field. And there is a podcast named after Dr. Hauer called The Hauer Hour.
I didn't start it.
She did not start it. It was a doctor named Emma Jones. But it says it's dedicated to gentle power and leadership, which I think is a great way to describe Dr. Hauer. Your books are amazing. They've done so much to help our parents, and they've done so much to help our providers and caregivers. And I think you do a great job empowering parents. A question that I have that I wonder if you could kind of teach us about is, as we do have these conversations with parents and try to navigate that power dynamic, there are times when I think parents are disempowered and are not listened to enough. And we do also find ourselves in tricky spots where a parent says, well, I'm their parent, I know best. And we find ourselves at odds with something that a parent is either requesting or demanding in some way. What are some ways that you've found helpful to navigate situations like that?
Yeah, thank you. And I so appreciate, because to me this is even more important than what I just did, but I feel like having a foundation to keep working from. So the first thing that comes to mind is time. And it's the part that goes against the time frame in the hospital. And I think just by acknowledging that up front, that means that the time that's needed to revisit a trusting that a parent can trust a team to start with, that they have some team that can become their foundation. Another part is how what makes it also hard for the parents that have a harder time trusting because of their fears, that it's also hard to navigate with the same team, meaning some parents benefit, and they'll describe this, they didn't realize it, that they need to know that teams are working to make their child better. And they can, then that creates a space where they can even start, know that might not be possible, but that fear that if, and I know intense, please know, anyone who's an intensivist listening, I know from the work and the individuals going into ICU that there's amazing skills at navigating this, but it's that reminder that, again, just like I said, sometimes I have to say the social worker needs, that parent needs private space with that person. Just like the parent needs space with someone who's not responsible for the day-to-day care. And I know you kind of know that, and you have palliative care involved. I think what gets is hard to appreciate is because in palliative care we understand that that things take time. Time can be weeks, and that can feel like a long time. It can feel like a long time for me. When I come back to that, like in the hospital setting, what is a long time frame is still just a blip for the parent who has lived with this impact for their child. So I always feel like in the hospital setting, if we can come to shared understanding and give permission for time that's needed, and equally be really frustrated for the time that's needed. So I know that that isn't necessarily getting at the solution, but because rather than it feeling like this increasing drama, which is understandable because it's hard, that how can we find ways to say, we have to figure this out in a different way. This is not a time to keep returning to information. And in fact, there's this really nice, simple statement. When is something an information need and when is something an emotional need? And it kind of makes sense when you think about it. None of us can make an information decision if we have a lot of emotion that is that more dominant than processing that. So it's kind of, I always call it, there's a leap of faith that because we're not going to change it with the current model, we have to rethink the model that's going to make best sense. And the model is going to require time. And then the other part is, for me, being very explicit in coming back to those basics. I have to imagine it feels like the team is giving up on grace. I want to just acknowledge that the same care is going to continue. We're not going to focus on any care decisions. The same care is going to continue. We want to understand what this has been like for you. And I know I'm just naming what is a lot of the work. I imagine your team ends up being involved is listening. And then it becomes reflecting back to teams. And I know, again, the hardest part is it's not that it's ever going to be an easy solution, but it's the more that there's dialogue away from an intense patient need to be prepared that, okay, this is part of the work of these types of children, so that there's also enhanced trust that can be also filtered back to bedside nurses. That I think the biggest fear is that everyone's just kind of giving up and letting the parent drive versus, oh, we actually know there's a system in place. We just have to believe in that system. And we also know that that process for a parent with such intense statements that are being shared means that it can take time. So I don't know if you want to add anything else to that, but I just wanted to kind of name a couple of components with it.
Oh, thanks so much. Thank you.
Yes. Oh, for you got first in the back.
Hit the buzzer first.
Yeah.
Can you describe, that was a great presentation, by the way. Can you describe how you and your team handle abusive behavior on the part of parents?
Oh, yeah. Yes. So I can immediately think of the most intense circumstance that evolved over 5 years and just finally resolved this year, or improved after like three years. It really was about identifying a shared decision as to when to end a conversation, so that it was just acknowledging that it was acknowledging with the parent that this is important. We know that it's hard to have conversations when it becomes more heightened, and we're going to put this aside. So it's trying not to make it into, and then there's the separate, which is when something seems abusive. I certainly know that the people experiencing it, so like in my work, I don't directly experience it as much as the bedside nurses. That's kind of what it gets down to. And so it's, we have team meetings so that there's this active effort taking place behind the scenes. We give them kind of scripts of how to disengage, literally, in that, attempting not to worry about the worst, so that it's not introducing. We may have to, use the, call security as an example. Obviously, things could escalate where that might be needed, but the idea is usually things when there's kind of a few, literally like one line to say, describe, kind of talk about the types of circumstances seen, so that it's figuring out how to de-escalate. The other way we do that is when things are escalating, because there's always a supervisory nurse, is that the supervisory nurse is better suited because they're not directly involved, and just gently coming in, redirecting the parent, putting them in a different location, so that the onus isn't on the bedside nurse specifically. I should have said that at the beginning. Other comments that people want to add to that?
We do have a new disruptive visitor, disruptive family members like protocol.
Yeah, I mean, I think the long-term, we have the hospitalization, but the long-term care really requires trust and a therapeutic relationship.
Yes.
But sometimes, we cannot get trust, and it
Yes.
and it borders on abuse. It's not on it's not on the nurses, it's the resident staff, or it's the trainees, or it's the nurses in the outpatient clinic.
Yeah.
And it's a really big challenge, and it totally interferes with the kid's care. And it's just a comment. I don't have a good answer. I do appreciate that. It's like care. It's really hard.
Yeah.
It's getting worse, I think, but
The expectation, when everything is creating other external worries, it just heightens everything. And another thing, like the example I was alluding to, another thing we did is we actually re-identified who best to utilize. And actually, this is a great opportunity for me to share. I wasn't and sorry for the wrong term, but I wasn't the solution. I thought I had failed because I'd used all my best techniques and I wasn't developing that therapeutic relationship. And it's important that we not see it as our failure. I'm not suited to this individual at this point in time after that year of effort. So we shifted the primary focus to the nurse practitioner. Everything was done with the social worker and my involvement so that she didn't feel alone. And then this will sound odd, but we actually did a lot of our follow-up by email. Yeah, and it was, and what we learned, and this, I wanted to name that because for some families, they themselves know they have a low trigger, and that when they have time to process information, and it was went counterintuitive to our thought that you shouldn't put these things in an email, but as we would share information, we could be more specific about what we're sharing, things that we would feel better sharing in person, but we also found that because it always gave this individual time to prepare, that was a game changer.
Having the asynchronous kind of takes some of the heat off of it.
Yes, exactly. And because the mom is smart and articulate, we were kind of surprised, but it was that probably this was a, we could never get to the heart of it, but a trauma-informed process that we're allowing her to be reactive to information and then process information and then have conversation about information was, again, a game changer. Yes.
I feel like I'm asking a similar question, but more targeted. But hi, I'm Rebecca. I'm a hospitalist, and I also run our fellowship. And I give them your book is like their entry. So, thank you for allowing me to have that resource, and making that resource. And so as a hospitalist, we're often sort of like the storm has calmed.
Yes.
Unsure if this is a decline, return to baseline, return to good baseline. I feel like myself and many of my colleagues, it's part of your skill set to know when to give information and when to validate emotion and listen, read the room correctly. And so my question essentially is when to introduce, because now the storm, maybe it was introduced in the ICU, but everything's too crazy and chaotic and scary. The best way to introduce that concept when we think they're in a place to listen, which we're not always right about, because often it does elicit anger, because it's triggering trauma from the NICU, whatever was said in the NICU, whatever they heard, and it triggers what the prognostic was when they were an infant. And I was trying to hold on to all the language you gave. And do you ever think, do you have the permission to talk about what going home might look like? Or you use the word "I'm worried," and almost like you were using it as like an entryway to have the conversation. And so I guess my question is, if we think it's the right time to talk about this, because sometimes care conferences are not they're almost heightened before they get there because it's so formal. I guess, what is the best way to present the conversation? And especially knowing that the conversation can trigger, even if you think you've read the room perfectly, this is the time.
Yeah. So again, what first comes to mind is that there is something relevant to reflect on. It's not about something I'm worried about, but I'm not even sure if I should be worried. Versus there's something that's very specific about this child that can be named, and then what that might mean, and then naming it, and then acknowledging. But the other part is I would never name something where if I didn't know there was a mechanism to follow up on that. So first things that are introduced that get at the longitudinal picture, and this is, again, I can just best call it a hypothesis. The question is that something better introduced once things have settled out and a child's at home? There still is reason to introduce, and I'll just add into the worry part a little bit that in palliative care we often talk about, I wonder, I worry. And so that it's being able to show that what is being done to achieve what is desired while also introducing, we know not every child will have that benefit. This would be what might occur when Grace goes home. So if that's helping, it's trying to make sure we're not introducing a more nebulous concept is the main thing. That it has to have specifics that are relevant to the child. So that's why I gave the examples of like the risk of respiratory failure. There has to be a reason for risk that can be named. Because parents often will ask, well, why might that happen? And then some of the details can be discussed in as broad a manner as possible. Versus, you know how sometimes parents get the sense that there's this nebulous, well, she's fragile. That actually is too open-ended, and it introduces a worry without understanding, well, how do they know, or what does that even mean, if that's making enough sense?
Yeah.
The other part I didn't share earlier, the hardest part is this is a process that sometimes unfolds over years. Because we can achieve a good enough recovery many times. And the other part is to be confident and believe that the good enough is occurring that we're not seeing. I'm sure some of you are familiar. So Jory Bogutz, who's in palliative care, also has kind of work in complex care, but she works on photonarrative as one way to get to know a child in the hospital setting, but it's a reminder that how that can have great impact in follow-up. But I know what you're getting at is what makes sense to explore in the acute setting versus what can be explored later. The other part of this gets at a system because there is not there's often not the level of personnel for the ongoing reflection longitudinally because there are a growing number of children. And so that leaves this dilemma of, but how and when is it occurring? I know there are great people here, and I have to imagine that's also hard to achieve for every family. And the families who intuitively do this often are good at accessing us. The families who are more disenfranchised are actually the ones who need it more, but we don't have good mechanisms to kind of get them what they need. And I just share that because I guess the best thing for me to end with is to know that you are providing exceptional care as individuals, teams, and system. And we all recognize some of the limits, and that's why we have these conversations. And for me, it always gets back to we have to think from a systems level of what is lacking and what is the impact of what's lacking. In this case, I don't see it as much the lacking of the medical care, it's the processing of impactful information that's paced to the family. Maybe that's the best way to end, and I've gone over my apologies.
Oh, that was perfectly in the pocket. Thank you so much.
Yeah.
Okay, thanks everybody. 40541.